Good morning, everyone. Today I have a very special guest. It is a great. Good morning, everyone. Today I have a very special guest. It is to me a great pleasure to introduce Dr. Debabrata Mukherjee, who is professor and chairman of the Department of Internal Medicine at Texas Tech University Health Science at El Paso, Texas. Deb has a remarkable career. I met him when he was a resident in internal medicine at the Cleveland Clinic, and I was a young attending at the time. Since then, he progressed to be one of the most productive fellows that we had at the clinic, very quickly advancing to what has been an amazing career. He was previously director of the Peripheral Interventional Program at the University of Michigan, moving to the University of Kentucky when he was the director of the Cath Lab, and now when he currently takes his position as professor and director and chairman of the Department of Internal Medicine in Texas. He's an expert in many, many areas, probably best known for his work in peripheral interventions. He has received multiple career development awards from the American College of Cardiology, the Memorial Award for Excellence in Health Outcome at the McKay Research Grant for Peripheral Arterial Disease. He's a member of the marquee Who is Who, one of the best doctors American for many 100 publications, and has edited 19 textbooks. His most recent one just came out, and I encourage all of you to take a look. His textbook of cardiovascular medicine, which is a phenomenal book. Right now, today, he will talk to us about the new guidelines for the evaluation and diagnosis of chest pain. Deb, thank you so much for sharing your wisdom with us.
Thank you, Dr. Garcia, for that very kind introduction. And thank you for inviting me and giving me the opportunity to talk to your group. So today we'll be looking at the evaluation and diagnosis of chest pain. And next slide. Okay. I'll be using the 2021 guidelines, the chest pain ACC/AHA guidelines to discuss the evaluation and management of chest pain. These guidelines came out late last year in December, and Martha Galati was the chair, Phil Levy and I were the co-chairs, and you can see a really accomplished group, writing committee members we had with expertise in many different fields. The objectives will be, we'll define chest pain in a slightly different or newer way. We'll look at initial evaluation. We'll look at cardiac testing general considerations. And I know Dr. Garcia is an expert on that. So I could learn from him regarding at least the non-invasive imaging part for the cardiac testing, and then choosing the right pathway with patient-centric algorithms for chest pain. For anybody presenting with chest pain, whether it's acute or stable chest pain, an initial assessment of chest pain is recommended to triage patients effectively on the basis of the likelihood that symptoms may be attributable to myocardial ischemia. We need to really risk stratify or categorize individuals and also determine how likely this is myocardial ischemia versus non-cardiac or chest pain from another cause. A key message from these guidelines is that chest pain should not be described as atypical, because atypical really doesn't convey any meaning. It tends to imply that it is benign in nature, but at the same time, we say women, diabetics, elderly may present with atypical chest pain, meaning that it could be ischemic. Instead, the guidelines suggest that chest pain should be described as either cardiac, possibly cardiac, or non-cardiac, because these terms are more specific to the potential underlying diagnosis and tells you what you are thinking. This figure shows the character of the pain and the probability of ischemia depending on the type of the pain. So if somebody is having central pressure, squeezing, gripping, heaviness, tightness, exertional stress-related pain, and retrosternal pain, the probability of ischemia is high versus sharp pain that's fleeting, shifting, pleuritic, or positional. The likelihood of myocardial ischemia, which we worry about, obviously, in somebody with chest pain, is likely to be low. Stabbing chest pain falls somewhere in the middle, and pain that is left-sided, dull, and aching is more likely to be ischemic versus right-sided, tearing, ripping, burning pain is less likely to be ischemic. And we'll see the tearing, ripping pain is more often used to describe the pain of aortic dissection. Our initial evaluation, history and physical is key for any medical condition, and chest pain is certainly no exception. In patients with chest pain, a focused history that includes characteristics and duration of symptoms relative to presentation, as well as associated features and cardiovascular risk factor assessment should be obtained. The nature of the pain is important. Anginal symptoms are perceived as retrosternal chest discomfort, that is pain or discomfort, heaviness, lightness, tightness, pressure, constriction or squeezing. On the other hand, sharp chest pain that increases with inspiration and lying supine is unlikely related to myocardial ischemia or ischemic heart disease, that these symptoms usually occur with acute pericarditis. Regarding onset and duration, anginal symptoms typically gradually build in intensity over a few minutes. Sudden onset of ripping chest pain or tearing chest pain with radiation to the upper or lower back is unlikely to be angina and should make you think of an acute aortic syndrome. Fleeting chest pain of few seconds duration is unlikely to be related to ischemic heart disease. And regarding location and radiation, pain that can be localized to a very limited area and pain radiating to below the umbilicus or hip are unlikely to be related to myocardial ischemia. It's important to ascertain the severity of pain. Ripping chest pain, worst chest pain of my life, especially when sudden in onset, occurring in a hypertensive patient, or somebody with a known bicuspid aortic valve or aortic dilatation, is suspicious of an acute aortic syndrome or aortic dissection. How about precipitating factors? Typically, physical exercise or emotional stress are common triggers of anginal symptoms. When somebody has pain at rest or with minimal exertion associated with anginal symptoms, think of an acute coronary syndrome. And positional chest pain is usually non-ischemic. Regarding relieving factors, relief with nitroglycerin is not necessarily diagnostic of myocardial ischemia and should not be used as diagnostic criteria. Certainly GERD, esophageal spasm, other pain may actually get relief with nitroglycerin and should not make you think automatically of myocardial ischemia. Associated symptoms are important. Common symptoms associated with myocardial ischemia include, but are not limited to, dyspnea, palpitations, diaphoresis, lightheadedness, pre-syncope or syncope, upper abdominal pain or heartburn unrelated to meals, and nausea or vomiting. Symptoms on the left or right side of the chest, stabbing, sharp pain, discomfort in the throat or abdomen may occur in patients with diabetes, women, and elderly. And in the past, we used to call these atypical symptoms, but I would likely call them possibly cardiac now instead of using the term atypical. Just like history, physical examination is key in the evaluation of somebody with chest pain. In patients presenting with chest pain, you need to do a focused cardiovascular examination to aid in the diagnosis of acute coronary syndrome and potentially elucidate other serious causes of chest pain, aortic dissection, pulmonary embolism, esophageal rupture, and to identify complications of an acute coronary syndrome. Physical examination, specifically in patients with chest pain and ACS, may include, they may appear diaphoretic, tachypneic, tachycardic, hypotensive. They may have crackles or rales, S3 gallop, mitral regurg murmur, especially if it is new. But you need to be aware that examination may be normal in uncomplicated cases. Individuals with pulmonary embolism, they are typically tachycardic, dyspneic in more than 90% of the patients. And some individuals may have pain with inspiration or pleuritic kind of pain. Regarding aortic dissection, if they have connective tissue disorders like Marfan syndrome, that should make you think of aortic dissection. Pulse deficit or pulse differential is seen about a third of patients, typically more commonly seen in type A dissection. If somebody has severe pain, abrupt onset, and pulse differential or pulse deficit, and a widened mediastinum on chest X-ray, there is an 80% probability of dissection. You can see syncope in about 10% of individuals, and aortic regurgitation is fairly common, though clinically the murmur may be hard to elucidate. Remember, these individuals are in severe pain and trying to sit them up and breath held in expiration. Also, the LVEDP goes up pretty quickly in acute aortic regurgitation, but on an echo, you can see 40 to 75% of individuals with type A may have some degree of aortic regurgitation with aortic dissection. Another life-threatening condition that may cause chest pain is esophageal rupture. And these individuals present with MSC, sub-Q emphysema, pneumothorax in 20% of patients, unilateral decreased or absent breath sounds. Regarding testing in different settings, office versus the ED, unless a non-cardiac cause is evident, an ECG should be performed for patients seen in an office setting with stable chest pain. And if an ECG is unavailable, the patient should be referred to the ED so one can be obtained, which is a class 1 recommendation. And patients with clinical evidence of acute coronary syndrome or other life-threatening causes of acute chest pain seen in the office setting should be transported urgently to the ED, ideally by EMS. And you'll see what the guidelines are saying is that don't wait to get an EKG. If a machine is not readily available, you have to get from somewhere else. Don't delay, get them to the ED. But if you have an ECG readily available, you should try to get an ECG and interpret it within 10 minutes. In all patients who present with acute chest pain, regardless of the setting, an ECG should be acquired and reviewed for STEMI within 10 minutes of arrival. In all patients presenting to the ED with acute chest pain and suspected acute coronary syndrome, cardiac troponin should be measured as soon as possible after presentation. And patients with acute chest pain, suspected ACS who initially come to your office, don't delay transfer. It's a class 3 recommendation and may cause harm. Don't wait for an ECG. Don't try to get point of care troponin. If you're worried about an acute coronary syndrome, just get them to the nearest ED through EMS where they will get appropriate care. Additional recommendations for ECG in patients with chest pain in which an initial ECG is non-diagnostic or benign, serial ECGs to detect potential ischemic changes should be performed, especially when clinical suspicion of ACS is high, symptoms are persistent, or the clinical condition deteriorates. Patients with chest pain in whom the initial ECG is consistent with an acute coronary syndrome should be treated according to STEMI or non-ST-ACS guidelines. And in patients with chest pain and intermediate to high clinical suspicion for acute coronary syndrome in whom the initial ECG is non-diagnostic, and if you're worried about a left circumflex infarct, supplemental back leads or ECG leads V7 to V9 are reasonable. It's a class 2A recommendation. If you're worried about the patient is having an MI and a posterior MI where the baseline 12 lead EKG, the routine EKG may be fairly unremarkable. This is an algorithm for an ECG directed management of chest pain. So again, somebody comes in with acute chest pain, you get a focused history and physical, you do an ECG. If there's STEMI, it's a no-brainer. They go to the cath lab in the US. If they have diffuse ST elevation consistent with pericarditis, You manage pericarditis, could be non-steroidals, could be colchicine. If they have ST depression, if they have new T-wave inversions, you follow the non-ST-ACS guidelines and further risk stratify them. If the initial EKG is non-diagnostic or normal, which happens in the majority of chest pain presenting to the ED, is non-cardiac. So the ECG is unremarkable. You can repeat an ECG if symptoms persist, or if troponins are positive, and then you can get back leads. If you're worried about a posterior MI, you can get leads V7 to V9. And if somebody is having an arrhythmia, for example, AFib can sometimes present with chest pain, you just follow the arrhythmia-specific guidelines. A simple test that is a class 1 recommendation in anybody presenting with chest pain is a chest X-ray, and it can help you with potential cardiac, pulmonary, and thoracic causes of symptoms. Biomarkers are key in the diagnosis of chest pain. In patients presenting with acute chest pain, serial troponin, either T or I levels, are useful to identify abnormal values, and a rising or falling pattern indicative of acute myocardial injury. In other words, you want to see the temporal change. If it's stable and it's unchanged, it's unlikely to be myocardial injury. In patients presenting with acute chest pain, high sensitivity troponin is the preferred biomarker because it enables more rapid detection or exclusion of myocardial injury. And increases diagnostic accuracy. So the penetration of high sensitivity troponin is not as great as in Europe, but I think it's increasing in the US. And certainly if available, high sensitivity troponin is preferred over traditional troponin assay because it can lead to a quicker diagnosis. It's important because with all of the newer high sensitivity troponins available, you'll see the cutoff values are very different. The values are gender specific, the deltas or changes are different. It is important that clinicians familiarize themselves with the troponin assay available at their institution. And with availability of cardiac troponin, particularly high sensitivity troponin, CKMB and myoglobin are not useful for diagnosis of acute myocardial injury. And I don't think there is a hospital that does not have troponin in this day and age. So these other biomarkers are not useful. Now we move on to who needs testing. This is kind of a 10,000-foot view of which individuals would benefit from testing. Asymptomatic individuals obviously do not need testing. A key message from these guidelines is low-risk individuals, and we'll define who low-risk are for patients presenting with acute chest pain, typically does not need any testing, and they can be discharged from the ED. We know the hospitals are full today, still 2 years into COVID, and this will help unclog your ED, that if they can go home, they can follow up with their PCP cardiologist. There are options of doing testing later on, which may include a coronary calcium scan in low-risk patients or an exercise ECG. The individuals who benefit most from testing, whether it's acute or stable chest pain, are the intermediate risk or intermediate to high risk. And today we have two options, an anatomical testing or a functional testing. Now, anatomical testing is coronary CT angiography, and functional testing, there's a plethora of different imaging modalities of stress imaging, including stress echo, stress PET, stress PEC, stress CMR, and we'll look at the role of this testing. People with ACAs and truly high risk often may go to the cath lab. Some intermediate to high risk individuals may get additional risk stratification with either a CTA, coronary CTA, or stress imaging. Choosing the right diagnostic test, these are general guidelines. I think the key is what is done well at your institution. That is very important, and that's one of the key metrics in choosing the right test. But the guidelines wanted to give clinicians some general principles. Again, low-risk patients, no testing necessary acutely. You can do a coronary calcium scan, exercise EKG for further risk stratification. Based on currently available imaging data, if individuals with intermediate to high risk, the younger patients, CCTA or coronary CTA appears to be preferred or favored. And for intermediate to high risk patients who are older, stress testing is preferred. Again, these are general guidelines on what favors CCTA and what favors stress imaging. CCTA can rule out both obstructive and non-obstructive CAD. So it's an anatomical test unless you do FFRCT and can get you an idea of ischemia. Versus stress imaging will tell you about the ischemic burden. Availability and expertise is key for both modalities. What is available at your institution, high quality imaging, and expert interpretation. We talked about, again, likelihood of obstructive CAD. People, younger people like less than 65 favor CCTA, age more than 65 favors use of stress imaging. And again, if you have a prior stress imaging that was inconclusive, you can do a CTA. And if there is a prior CTA that was inconclusive, stress imaging is reasonable. Other advantages of CCTA, you can diagnose anomalous coronaries, you can get some evaluation of the aorta and pulmonary. And the advantage of stress imaging, you can look at scar, and certain modalities like PET and CMR can give you an idea of coronary microvascular dysfunction in the subset of individuals with non-obstructive CAD and ischemia, or also known as INOCA. And then stress testing, people have to be able to exercise for exercise stress test. And if you do stress echo and SPECT MPI with exercise, certainly they need to exercise. You can do stress echo, stress SPECT, PET, and stress CMR pharmacologically. And then particularly with PET and stress CMR, you can get a quantitative flow and get an idea of LV dysfunction and scar with all of the imaging modalities. As we look at patients with chest pain, it's important to be structured and use patient-centric algorithms, particularly if you're going to discharge your low-risk patients. So in patients presenting with acute chest pain, suspected ACS, clinical decision pathways should categorize patients into low, intermediate, and high-risk strata to facilitate disposition and subsequent diagnostic evaluation. In the evaluation of patients presenting with acute chest pain and suspected ACS for whom serial troponins are indicated to exclude myocardial injury, if you're using the traditional troponin assay, the guidelines still say 0.36. And if you're using the high sensitivity troponin, you actually, depending on the particular assay, it could be 0.13 or 0.12. And there are some newer assays with 0.30, 1 hour assays also to rule out myocardial ischemia. To standardize the detection and differentiation of myocardial injury in patients presenting with acute chest pain and suspected ACS, institutions should implement a clinical decision pathway that includes a protocol for troponin sampling based on their particular assay. I'm not going to go over the details of each of these assays, but if you look at the cutoff values are different, there are gender-specific values for each of these assays, and the delta is different for this assay. So any clinical decision pathway for your institution should incorporate the particular assay that is being used in your institution. Similarly, if somebody has had prior testing, they had a CCTA 6 months ago or a myocardial stress study, that data should be incorporated into your clinical decision pathway. If somebody has acute chest pain, unremarkable or normal ECG, and symptoms suggestive of ACS that began at least 3 hours before ED arrival, in this scenario, a single high sensitivity troponin concentration that is below the limit of detection, an initial measurement is reasonable to exclude myocardial injury. And what it does is facilitates ED discharge, but the pain must have started at least 3 hours before they came to the emergency department. This is an algorithm for general approach to risk stratification of patients with suspected ACS and acute chest pain. So again, we always start with history physical, do an ECG. And if there's an obvious non-cardiac cause, we don't need to do additional cardiac testing, at least acutely. Individuals with obvious non-ischemic cardiac cause, hypertrophic cardiomyopathy, aortic stenosis, they may need additional testing. Could be an echo, sometimes echo with stress or vasodilator testing, depending on the pathology, but not myocardial ischemia testing. And then if you're worried about possible acute coronary syndrome, it's key to get troponin today's day and age. Better to use high sensitivity troponin if available at your institution, and then use clinical decision pathway. If they are designated low risk based on your CDP or clinical decision pathway, they can be discharged home. That again is a recurring and key message from these guidelines. If they're intermediate risk, these are the individuals who benefit most from testing. They get further diagnostic testing, and in individuals, whether you get CCTA and shows obstructive coronary artery disease or moderate to severe ischemia, on a stress imaging, they go to invasive coronary angiography. In high-risk individuals, and we'll look at what that entails, hemodynamic instability, ongoing chest pain, EKG changes, they may go directly to the cath lab, certainly people with acute coronary syndrome. We've been talking about, this low risk, intermediate risk, high risk. So particularly, how do we define these categories? There are many different clinical decision pathways that have been used. The heart pathway is very commonly used in the US. We'll look into that. There are other scores, EDAX, ED assessment of chest pain score, the ADAPT score, the modified ADAPT score, the NOTER or no objective testing, and the 2016 and 2020 ESC clinical decision pathway that heavily uses the troponin levels, the high sensitivity troponin assays to delineate or risk stratify individuals. The goal is simple, to rule out ACS and get them out of the ED if they are low risk. And as you can see, the patients with cardiac ischemia or ACS is very low typically in most ED populations, whether it's done in the US or in the Europe. So there's a tremendous opportunity to get these low risk patients out of the ED and without admitting them to the hospital. And they do need workup. Sometimes they may need additional testing, but can be done in an outpatient setting. The heart pathway, I'm sure all of you are familiar with, looks at history, ECG, age, risk factors, troponin. EDAX looks at, or the variables are age, sex, risk factors, history, troponin. ADAPT uses the TIMI score, ECG changes, troponins, and no objective testing does look at very heavily on the troponins, but also age, risk factors, previous MI, CAD. And the 2016 and 2020 ESC uses a troponin very heavily, but also look at history, ECG. In the older 2016 CDP used age, heart rate, serum creatinine, cardiac arrest, ECG, cardiac biomarker, CALIP class. Low risk has been defined by the American College of Cardiology as patients with acute chest pain and a 30-day risk of death are less than 1% as low risk, and we'll work on identifying them. In patients with acute chest pain and suspected ACS who are deemed low risk, it's reasonable to discharge home without admission or urgent testing. We've been talking a lot about low risk. So who are these people? These are individuals whose initial troponin is below the assay limit of detection or very low, and their repeat troponins remain below the assay threshold of more than 99%. In addition, if you're using a CDP or clinical decision pathway, low risk is heart score less than 3, an EDAX score of less than 16. For ADAPT and modified ADAPT, TIMI score of 0 or 0 to 1, and negative troponins or initial and serial troponins stay below the assay 99th percentile, and for the NOTAR or no objective testing, 0 factors or 0 risk. Let's move on. Having looked at low risk and that they don't really need urgent testing, they certainly need to be seen by a PCP or a cardiologist later on. The intermediate risk patients are the patients who benefit most from testing. For intermediate risk patients with acute chest pain, transthoracic echo is recommended. It's a rapid bedside test to establish baseline ventricular and valvular function, evaluate for wall motion abnormalities, and to assess for pericardial effusion. So this is a class 1 recommendation to get an echo in intermediate risk with patients with chest pain and can give you valuable information. A class 2 recommendation is instead of admitting them to the hospital, you can put them in a chest pain unit or in an observation unit to shorten length of stay and lower cost relative to an inpatient admission. And you really need a hospitalist or a physician who is there 24/7 to quickly look at tests and their results to get them discharged. We'll now look at imaging for intermediate risk patients with acute chest pain and no known CAD eligible for diagnostic testing after a negative or inconclusive evaluation for acute coronary syndrome. Coronary CTA is useful for exclusion of atherosclerotic plaque and obstructive CAD. You basically will have two choices as we look at individuals with acute chest pain: coronary CTA or a functional testing with some sort of stress imaging, and they're both class 1. You choose the one that you are most comfortable with in your hospital. For intermediate risk patients with acute chest pain who have had moderate severe ischemia on current or prior stress testing, and if they did not have a cath before, invasive coronary angiography is recommended. For intermediate risk patients with acute chest pain with evidence of previously mildly abnormal stress test results or non-obstructive CAD, a CCTA is reasonable for diagnosing obstructive CAD, and we'll look at an algorithm on how that is helpful. We talked about anatomical testing in the prior slide. The same intermediate risk patients with acute chest pain and no known CAD who are eligible for cardiac testing, you can do some sort of stress imaging too, or exercise ECG, stress echo, stress PET, stress PEC, stress CMR. These are all class 1 recommendations. Let's try to put it together. So these are individuals with suspected ACAs at intermediate risk without known CAD. If they had prior testing, and if they had a recent negative CCTA, negative recent stress myocardial perfusion within a year, that's kind of loosely the warranty period for stress imaging, then they can be discharged with follow-up with their cardiologist or PCP. Now, if they had a test before, which was a prior inconclusive or mildly abnormal stress test within a year, a CCTA is reasonable. And if you do a CCTA urgently, and if you find non-obstructive CAD, you can get them out of your ER. You may want to consider INOCA workup outpatient in this individuals after you put them on guideline-directed medical therapy. Now, if they have intermediate stenosis, anywhere we call it, 50 to 70, or some of the CT studies, it was 40 to 80, you can either do stress imaging or an FFR CT if it is available in your institution. If FFR CT is more than 0.8, or if there is no ischemia, if you do a stress test, they can be on guideline-directed medical therapy discharged. If you do an FFR CT, which is less than 0.8, or if they have a stress test that shows moderate ischemia or moderate to severe ischemia, they need to go to the cath lab, obviously. Now, if they have obstructive more than 50% stenosis, and this is high risk, they have left main, they have proximity, they have multivessel disease with frequent angina, these are individuals that go to the cath lab directly individuals who have not had prior testing, you can start with some sort of stress testing, exercise ECG, stress CMR, stress echo, stress PET, stress PECT, or an anatomical test like a CCTA, and further risk stratify. Non-obstructive stenosis, no evidence of ischemia, goes home. People with moderate to severe ischemia, they go to the cath lab. Now, if you do CCTA and if you have FFRCT in your hospital, you can do an FFRCT. And again, FFRCT less than 0.8 or moderate to severe ischemia, they go to the cath lab. If they're mild ischemia, FFRCT more than 0.8, they can be treated with guideline-directed medical therapy and they can be discharged. The recurring theme again, low-risk patients go home, discharge, moderate to severe ischemia, they need invasive angiography, and you can either use anatomical testing with CCTA, with FFRCT if available in your institution to further risk stratify them, or you can use a stress imaging depending on expertise at your institution. And inconclusive stenosis and their non-ischemic or symptoms do not persist can be treated medically. The high-risk patients, again, go to the cath lab. For intermediate risk patients with acute chest pain who have known CAD and present with new onset or worsening symptoms, guideline-directed medical therapy is key. Whatever you do, they may get revascularization or not, but they need to be on guideline-directed medical therapy to improve their survival. For intermediate risk patients with acute chest pain who have worsening frequency of symptoms with significant left main, prox LAD, multivessel CAD on prior anatomical testing or history of prior coronary revascularization, you go to the cath lab. So you do a CCTA and they have significant high-grade stenosis in this area, so obviously certainly with prior anatomical testing, or they have had prior coronary revascularization, they would need to go directly to the cath lab. Now, if they had prior non-obstructive CAD on a CCTA, you can do a repeat CCTA if it has been a year to see if there has been progression, and that is a class 2A recommendation. We previously looked at an algorithm for individuals with intermediate risk without known CAD. This is an algorithm for individuals with intermediate risk, but with known CAD. And again, if they had non-obstructive CAD in the past, they can get a repeat CCTA if it's been more than a year. If there's no change, no progression, they can be discharged. If they have obstructive stenosis and if you have FFRCT, again, risk stratify them. FFRCT less than 0.8, or they get stress testing or stress imaging, they get moderate severe ischemia, they'll go to the cath lab. Instead of CCTA, you can risk stratify them with stress testing. Again, all of the modalities, stress imaging, CMR, echo, PET, SPECT can be used to further risk stratify them. And depending on the results, again, if they are moderate to severe ischemia, they go to the cath lab. If they have normal functional test, they can be discharged, follow up with their cardiologist. And the high-risk patients with obstructive CAD with persistent symptoms, again, go to the cath lab. We've looked at low risk. We have looked at intermediate risk. Now let's look at high risk. These are typically the individuals who need to go to the cath lab. And who are these individuals? For patients with acute chest pain with suspected ACS who have new ischemic changes on ECG, they have troponin positive confirmed acute myocardial injury, new onset LV dysfunction, newly diagnosed moderate to severe ischemia on stress testing, hemodynamic instability, they're hypertensive tachycardia, high clinical decision pathway score, whether you're using HARD, EDAX, or one of the troponin-based assays for risk stratification. These are high-risk individuals for short-term MACE, and they should go to the cath lab, which is a class 1 recommendation. So again, people with suspected ACS who are high risk, invasive coronary angiography is recommended. Now, individuals who are troponin positive, which suggests myocardial injury, but we have ruled out non-obstructive, or we have ruled out obstructive CAD. You can look at CMR or PET or echocardiography in establishing alternative diagnosis, and we'll look at what this may be. In patients with acute chest pain in whom other potentially life-threatening non-ischemic cardiac conditions are suspected, example, aortic pathology, pericardial effusion, endocarditis, transthoracic echo is recommended. In patients with acute chest pain where there is clinical concern for aortic dissection, CTA is currently the test of choice. And you want to do a CT of the chest, abdomen, and pelvis to make sure you can define the extent of the dissection. Again, if there is clinical concern for aortic dissection, TE or CMR should be performed to make the diagnosis if CT is either contraindicated or unavailable. How about PE? In stable patients with acute chest pain with high clinical suspicion for PE, again, the test of choice today is a CTA. And for patients with acute chest pain, possible PE, use pretest probability, a Wells score or something to determine need for additional testing. In patients with acute chest pain and myocardial injury who have non-obstructive coronary arteries on anatomical testing, CMR with gadolinium is effective to distinguish myopericarditis from other causes, including myocardial infarction and non-obstructive coronary artery or MINOCA. In patients with acute chest pain and suspected acute myopericarditis, CMR is useful if there is diagnostic uncertainty or to determine the presence and extent of myocardial and pericardial inflammation and fibrosis. These are both class 1 recommendations. In patients with acute chest pain, if you are suspecting myocarditis, a transthoracic echo is also class 1 recommendation to determine the presence of ventricular wall motion abnormalities, pericardial effusion, any valvular abnormalities or restrictive physiology. In patients with acute chest pain with suspected acute pericarditis, non-contrast or contrast cardiac CT may be reasonable to determine the presence and degree of pericardial thickening. How about individuals with chest pain and valvular heart disease? Transthoracic echo is class 1 and helpful in determining the present severity and cause of valvular heart disease. And typically we're thinking of individuals with aortic stenosis, but could be other valvular pathology that may present with chest pain. In patients presenting with acute chest pain with suspected or known valvular heart disease, if your transthoracic diagnostic quality is inadequate, you can do a TE. And if both transthoracic echo and TE are non-diagnostic, cardiac magnetic resonance or CMR imaging is reasonable. It's a class 2A recommendation. We spend a lot of time with acute chest pain because obviously it affects hospitals day in and day out. It's one of the most common presentations in our EDs. Let's spend a few minutes looking at stable chest pain now. For patients with stable chest pain presenting to the outpatient clinic, we again need to risk stratify these individuals. A model to estimate pretest probability of obstructive CAD is effective to identify patients at low risk for obstructive CAD and favorable prognosis in whom additional diagnostic testing can be deferred. And again, low risk, there is no need for urgent testing, whether acute or stable chest pain. All of you guys are very familiar. This is kind of a old slide used very commonly, shows you the pretest probability of obstructive CAD based on gender, based on age and symptoms. And as you can see, as we get older, obviously the pretest probability is higher for obstructive coronary artery disease. And if you incorporate coronary artery calcium score, you can further refine the pretest probability. Again, the individuals who tend to benefit most from testing would be the intermediate risk, where the low risk testing can be deferred. Individuals who are low risk, you can think of further risk stratifying them with a calcium score to exclude calcified plaque and further identify individuals with a low likelihood of obstructive CAD. You can also use exercise testing without imaging as a first-line test in the low-risk patients. It will give you a great idea of their functional capacity. You have to have an interpretable ECG. And if they do well in the stress test, their risk of cardiac adverse events is fairly low. How about intermediate to high risk patients? We talked about that these are the individuals who benefit most. And again, the choices are anatomical testing. You can do CCTA, which is effective for diagnosis of CAD, for risk stratification, and for guiding treatment decisions. And similar to CCTA as an anatomical testing, you can do stress imaging, which could be stress echo, PET SPECT, MPI, or CMR to diagnose myocardial ischemia risk and estimate risk for MACE. For intermediate high-risk patients with stable chest pain, no known CAD for whom rest stress nuclear MPI is selected, PET is a better modality than SPECT. Again, if available at your hospital, it improves diagnostic accuracy and decreases the rate of non-diagnostic test results. And if you have an interpretable ECG in these individuals with intermediate, we saw that low-risk patients certainly exercise EKG. Even in intermediate risk patients, exercise ECG would be reasonable if they have interpretable ECG and they're able to exercise to max levels of exercise. And again, if you're doing MPI or myocardial perfusion imaging with SPECT, use of attenuation correction or prone imaging is reasonable to decrease the rate of false positive findings. This algorithm, we've looked at multiple algorithms for acute chest pain, for stable chest pain without known CAD. You again do a clinical risk assessment, which is history physical. If they're low risk, no testing recommended acutely. You can do coronary artery calcium or an exercise ECG. If they're intermediate high, these are the individuals who benefit from additional testing. You can do either CCTA, and if it is inconclusive, you can do stress testing. If they have no CAD, no stenosis or plaque, and they have evidence of myocardial ischemia, think of INOCA. And if they have non-obstructive CAD, and if you have FFRCT in your hospital, you can do FFRCT or you can do stress imaging. And again, if FFRCT is less than 0.8 or they get a stress test which shows moderate severe ischemia, they go to the cath lab. Otherwise, they can be followed up with intensification of guideline-directed medical therapy. And if they have obstructive CAD, high-risk CAD, obviously on CTA, and they have an FFRCT that shows less than 0.8, they go to the cath lab. Instead of CCTA, depending on institutional expertise, you can start with an imaging test, which is all of the modalities we've talked about. If they are inconclusive and they continue to have chest pain, invasive coronary angiography would be reasonable, or you can further risk stratify with CCTA. If they have mild ischemia or no ischemia, then you can treat them with medical therapy. You can do further risk stratification with coronary calcium. And again, the recurring theme, if they're moderate to severe ischemia, they go to the cath lab. If they don't have moderate to severe ischemia, you continue to treat them medically. These are individuals with stable chest pain with prior MI, prior revascularization, or known CAD. These are obviously higher risk than individuals without known CAD. And again, if they have non-obstructive CAD, you treat them with intensification. If they have persistent symptoms, risk stratify them with coronary CTA, with FFRCT, and if the FFRCT is less than 8.8, or they have stress test that shows moderate severe ischemia, they go to the cath lab, otherwise medical therapy. And if they had obstructive CAD known, you can intensify their guideline-directed medical therapy. And then if they have high-risk CAD or frequent angina, they go to the cath lab. If they don't have high-risk CAD on prior testing or frequent angina, you can risk stratify them with an imaging stress test. And then based on moderate to severe ischemia, they go to the cath lab. If they have no ischemia, they have mild ischemia based on contemporary evidence, they can be treated medically. People with prior coronary bypass is an especially high-risk group. And if people with prior CABG presenting with stable chest pain, who has a non-invasive stress test showing moderate to severe ischemia, they need to go to the cath lab. Now, if they had prior CABG with stable chest pain, suspected to have myocardial ischemia, but they have not had testing, you can do either CCTA or perform stress imaging. How about INOCA, which is more common than we think for patients with persistent stable chest pain, non-obstructive CAD? You can take them to the cath lab and do invasive coronary function testing with coronary flow reserve or myocardial reserve IMR. More likely than not, these days they go to the non-invasive lab. You can do PET MPI with myocardial blood flow for INOCA to determine myocardial blood flow reserve. You can do stress CMR in these individuals and also calculate myocardial blood flow reserve in individuals with INOCA. And there is emerging data that you can use stress echocardiography to look at coronary flow velocity reserve measurements in these individuals to improve diagnosis of coronary myocardial dysfunction. But the data is less robust compared to PET and CMR, so it's a class 2B recommendation. I'm going to end with some take-home messages from these guidelines. One thing is that chest pain is more than pain in the chest. And sometimes we ask a patient, are you having pain? They may say, no, I'm having discomfort, I'm having tightness. So this chest pain includes pressure, tightness, discomfort in the chest, shoulders, arms, neck, back, upper abdomen, or jaw, as well as shortness of breath and fatigue. And this should all be considered angina equivalents. In today's day and age, if you have high sensitivity troponin, they lead to more rapid diagnosis. They're more sensitive. You're unlikely to miss a myocardial infarction. So this is the preferred standard today, as opposed to the traditional troponin assay. Patients with acute chest pain should seek medical care immediately by calling 911. Most patients will not have a cardiac cause, but the evaluation of all patients should focus on early identification or exclusion of life-threatening causes. You really don't want somebody with an MI driving themselves to your ED. Here, the decision-making across the country in every cardiovascular condition, there is a huge impetus push to involve the patient, the family in decision-making, talk to them about the different tests, particularly in a hospital like yours where everything is available, talk about radiation, cost, alternative options to facilitate the discussion. A key message, you don't need testing urgently for low-risk patients, and these individuals can be safely discharged from the emergency department with good outcomes. Use clinical decision pathways rather than heuristics or gestalt to risk stratify individuals. Accompanying symptoms are important. Although men and women both present with chest pain, women are more likely to present with accompanying symptoms such as nausea and shortness of breath. It's important to identify patients most likely to benefit. These are the intermediate risk patients. Low risk patients, we say, don't need testing, and often high risk patients need invasive testing or to go to the cath lab. And again, a key message, atypical is out because it doesn't tell you much. It's a misleading descriptor. It tends to suggest benign, but then we say women, diabetics, elderly, atypical pain. So use cardiac, possible cardiac or non-cardiac, and use structured risk assessment both for stable as well as acute chest pain. The final slide is kind of the graphical description of the key messages that spells out chest pains. And I will stop there and happy to answer any questions.
Thank you, Deb. That was a great overview of a topic that upfront looks very simple, but I'm sure that it took a lot of debate to get this document together. I will start with probably the toughest question that I'm sure you guys have divided and ruminated for quite a while. I don't know if people in the audience will know, but we recently had here Randy Thompson from ASNEC, And ASNAC was one organization that, even though they have representative in the writing group, they decided not to endorse the document. And, I know it's very difficult to get a consensus between organizations. They all want to push their own agenda. I think to me, the two major arguments that they had to why they were not completely on board with the document is that they felt that there was an over-reliance on the FFR part of CT to make it sound like an equivalent to functional imaging. It is a technology that in some areas is still controversial to whether it's really functional or is a spin-off on an anatomic modality. And the other area that they, I think they have perhaps a point is on the absence of a comment on the combination of myocardial perfusion imaging with calcium scoring, which is something that can be done in some of the platforms that are used for nuclear imaging that have incorporated a CT. So I don't know. I'm sure that was debated in your group extensively, and I wanted to hear your opinion or the opinion of the group on those two issues.
So you're absolutely right, and I'll start with a disclaimer. You're an expert on imaging. I'm not. I'm interventional. This was an extremely contentious issue. We did have representation from ASNIC, two individuals. One is my colleague from Cleveland Clinic, too, while our group or the imaging experts in our group felt that it was what we suggested was fair. I tried to emphasize that do what is done best at your institution. The imaging societies, I think I'll start by saying all felt that everybody should be class 1, and we, to an extent, suggested that FFR CT is less available. There is at this point less data than, of course, myocardial perfusion imaging has been around for a long time. But the data that was presented to us, that was discussed at our group, tend to suggest that if done in a lab or in an institution that does it well, does provide household testing. The myocardial imaging with calcium is evolving, and I think some of the platforms are able to do it. There wasn't much data when we started it. It took us 2.5 years, Mario, and I think the thing that held us back was just the imaging portion. Everything else was done, and working with our group was pretty. There was, I would say, consensus, including the two individuals from ASNIC, looking at the data. ASNIC not only did not endorse, they actually wrote an op-ed in their journal. I think there's no good answer. My own gestalt is do what is done best at your institution. These are all evolving modalities, certainly coronary CTA. And I know you started coronary CTA even at the Cleveland Clinic many years ago. FFR CT is certainly evolving. The coronary calcium with myocardial perfusion will continue to evolve. But individuals should use the test they're most comfortable with and they feel like it's done best at their institution. There was certainly every imaging societies, including Echo Society, CMR, everybody, initially there was a lot of back and forth, and we looked at very critically at the data that was available. And really, I think the best way to look at it, these are all reasonable modalities if they're done well at your institution.
Thank you. Let's see if we have any questions for the audience. I'll having the opportunity open. Please use your chat or raise your hand to ask a question. So maybe you can comment a little bit on the the use of imaging in the ER, do you think right now the majority of patients that come to the ER should be imaged at the emergency room, or should they be discharged and be followed for imaging as outpatients?
The majority of the patients are low risk. I mean, 10 to 12% in most studies are truly myocardial ischemia. And I think the guidelines, as well as ACC choosing wisely, is the suggestion is discharge them from the ED and make sure, set them up with their PCP, with a cardiologist. It used to be that they needed some sort of imaging within 48 hours. We don't recommend that anymore. They need follow-up more than anything. But we do feel, based on if you can risk stratify using a clinical decision pathway, and could be just high sensitivity troponin. The Europeans do it very well. If they're low risk based on the high sensitivity troponin or CDP, they can safely go home and then get follow up with their PCP and could get, whether it's a calcium score or an exercise ECG, or even some sort of imaging, stress imaging. But I would say majority of individuals are low risk, and majority of them don't need to be in the hospital. Our hospitals are already getting flooded. Still, we have plenty of COVID patients clogging up the EDs.
Yeah, I would agree with that. Now, there's a group of people where that everyone feels a little bit uncomfortable to send home with after a single troponin. There are people that had a intermediate moderate risk, and the symptoms are equivocal. Try not to use the word atypical. We did some work when I was at Sinai on calcium score, and even though when the calcium score is non-zero, you can't really do much. There is a fair amount of this population, up to 50% or more, depending on their age, that will have a calcium score of 0, and with the advantage of looking at other pathology that might be in the chest. It's a scan that can be done without much intervention, doesn't require contrast, doesn't require beta blockers, doesn't take any much time. The radiation dose is very, very small. I'm surprised that has not been looked more in depth. There is some data that suggests that the likelihood of having obstructive CAD when you have a calcium score of 0 is practically 0 in the year. So the negative predictive value makes it very attractive, and it's something that can be done 24/7.
So no, that's a great point. And to be fair, we did discuss that, and there was some individuals from part of our constituency or writing committee SCCT felt we gave it a class 2A. That we said doesn't need to be done in the ED. Again, simply thinking of the, you're obviously at a premier institution, whether before you were at Sinai and obviously at Albert Einstein, but not all hospitals. Again, this will cause delays if they're getting calcium score and getting read 24/7 radiologist. We felt calcium score is reasonable as a class 2A, can be done outpatient rather than in the hospital. Certainly it's available if it's 24/7. If you have a radiologist 24/7, somebody quickly read it, or a cardiologist reading it, I think it's very reasonable. But we felt that if we give it a class 1 and say everybody needs a calcium score, that there may further clog up the ED and may not impact outcomes or management as much.
Very good. I think in the interest of time, we're going to stop here. Deb, this was terrific. Thank you very much. I hope that pretty soon we can have you here in person, and maybe talking about some of the topics of your passion. Certainly, peripheral interventions is also an area that we're very much interested on. So thank you so much for sharing your wisdom.
Thank you. Thank you, Mario, for inviting, and it will be my pleasure. Take care.
Bye-bye.
Bye.